Hello and welcome to this INI-CET recall session for this November 2023. Hope every one of you is fine and the paper went well. Now, one thing is for sure, means looking off about the questions that were asked in this orthopedic examination 2023 November session in INI-CET, that everything is going to be asked from your notes or what you are studying. Repeatedly they are asking the similar concept again and again with slight change in the language of the questions, with slight change in the options which are about to be marked. The questions were relatively simpler, they were straightforward as far as this orthopedic session was or is concerned. Now, starting with the first question, that 3-point relationship in the elbow joint is likely to be affected in all of the following cases except. Now, this is a kind of the question, it is a primitive kind of a question. It is not asked for the first time. These are the kind of the questions which they have asked right since 80s, right? 80s, 90s, these are the kind of the question they are asking. And in between somewhere, there was loss that these kind of the questions were not very frequently asked. Today, they have asked this question again, that 3 bony point relationship is likely to be affected in all of the following cases except. So first of all, what is 3 bony point relationship? As we have very thoroughly discussed in our sessions also, like if you know that the distal end of the humerus has got the medial and the lateral epicondyle. So there is a medial and the lateral epicondyle, and it is articulating, the trochlea is articulating with the olecranon process of the ulna. So the third point is the tip of the olecranon. Now, these 3 structures are related in a manner that when you flex the elbow to 90 degree, all right, when the elbow is flexed to 90 degree, this is medial epicondyle, this is lateral epicondyle, and this is the tip of the olecranon, they are responsible for creating an isosceles triangle. So medial epicondyle, the lateral epicondyle, and the tip of the olecranon, they are responsible for creating an isosceles triangle. Isosceles triangle is the triangle which has got 2 same sides, all right. So they are creating an isosceles triangle in 90 degree flexion of the elbow. Now, if the elbow is extended, when the elbow is extended, then all these 3 bony points, they form a straight line. So with the extended elbow, the medial epicondyle, the olecranon and the lateral epicondyle, they create a straight line. And this is what is known as 3 bony point relationship in a normal individual, where the range of movement is normal, where the range of movement is not affected, where the patient is not suffering from a fixed flexion sort of a deformity or a stiffness of the elbow, right? So this is what the 3 bony point relationship is, as it is very easily depicted in this image itself. Like one of the structure is medial epicondyle, the other one is the lateral epicondyle and the tip of the olecranon. And these 3 structures, so the lateral epicondyle, the medial epicondyle and the olecranon, they are creating a straight line when the elbow is extended with the extended elbow, and they are responsible for creating an isosceles triangle with the elbow flexed to 90 degrees. This is what the 3 bony point relationship is. Now, imagine if the structure that is medial epicondyle is fractured, if there is a fracture in the medial epicondyle, then obviously there is going to be a change in this 3 bony point relationship. If another of the component like lateral epicondyle is affected, there will be a change in the 3 bony point relationship. Even if the intercondylar region of the distal end of the humerus is fractured, if there is a fracture in the intercondylar region also, then also it is going to be affected. Even if there is a fracture of the olecranon, then this thing would be affected. So anything which is involving or being a part of this 3 bony point relationship, then it will result in the affection of this 3 bony point relationship. For example, if the patient on the left side is having a normal elbow, on the right side there is a malunited medial condylar fracture of the elbow, then it will result in a change or asymmetric 3 bony point relationship, right? So you have to compare it with the contralateral elbow of the same patient. Now, as you can very easily identify now that the supracondylar fracture means, supra means above the level of the condyles. So here somewhere the supracondylar fracture is happening above the level of the condyles, right? Which is not directly involving the medial epicondyle and the lateral epicondyle. So this becomes the identification criteria for supracondylar fracture of the humerus, that if a malunited supracondylar fracture, if the patient comes to you, then 3 bony point relationship is unaffected. It is maintained. All right. So answer for this question is obvious. That is supracondylar fracture of the humerus. So 3 bony point relationship not affected in which of the following elbow fractures? Answer for that question is supracondylar fracture of the humerus. Now, there are some prerequisites though, that the range of movement should be absolutely normal. Range of movement means the flexion and extension should be absolutely normal. All right. Imagine if the patient is presenting with the fixed flexion deformity of the elbow, then you cannot fix it into 90 degree of flexion and you cannot bring it into extended position. So the moment you cannot bring it into flexion or extension with the required categorization, then in that case, you cannot do this 3 bony point relationship. All right. So this is how you are going to mark the correct answer for this particular question. And that was asked, a very basic question on 3 bony point relationship asked. And the answer for that question is supracondylar fracture of the humerus. So many times this question has been repeated, right? Okay. Next is Hawkins classification. Again, it is extremely surprising to us. We used to teach this classification system. It is for the first time the question was asked. That Hawkins classification, we used to teach it, and by the time we used to teach it, there is a thing that we used to say is that, although we are talking about the name of the classification, we are asking you to learn the name of the classification, but we are not going deep into this classification system, because once the question is asked for the first time, imagine if the question is asked for the first time that what is the name of the classification for talar fracture, Hawkins classification, then subsequently we will start teaching the details of the Hawkins classification. And today, the question was asked. For the first time, the question was asked that Hawkins classification is for, answer for that question is talar neck fracture. It is for the talar neck fracture. And now, because the question become obvious that they have started asking about this Hawkins classification, then we have to talk about it. Before we talk anything related to this Hawkins classification, why the talar neck fractures are important? Why? Why the examiner has decided to give you the question out of talar neck fractures? Why? The reason is because of its complications. Every time you get a patient with a talar neck fracture, then the likely possibility of complications are too high. And the specific complications that we have to talk about are, the first one, secondary osteoarthritis. If the talar neck is fractured, then the degenerative changes in the ankle joint are inevitable. It will happen. And you have to counsel the patient before performing surgery, before performing the management, that, even if the bone unites successfully, even if the bone does not go into avascular necrosis, even then the patient would be having pain, which might persist throughout life because of the degenerative changes in the ankle, which are inevitable, which are bound to happen. All right. So that is a complication. Another complication is osteonecrosis, body of the talus. Osteonecrosis body of the talus. Why does it happen? Because of the non-union at the fracture site. So these are the 3 complications which you have to understand. And as I'm again repeating that while teaching this topic, that is talar neck fractures, we used to teach about the name of the classification, although it is the time where the name of this classification has to go into a deep study, that what are the characterizations, what are the classification criteria. Now, why this fracture is more bound to go into non-union or osteonecrosis? Because the vascularity to the body of the talus is not direct. The vascularity to the body of the talus is primarily dependent on the vessels coming from the head and neck to the body of the talus. So imagine if there is a fracture in this region, that is neck of the talus, then there is a likely possibility that there will be a cut in the vascular supply to the body of the talus, as a result of which it is more likely to go into osteonecrosis. So talar fractures, for talar fractures, Hawkins is the very important word because of 2 reasons. One is Hawkins classification and the second is Hawkins sign. And what is Hawkins sign? That you tend to look for osteonecrosis, head of the femur, 6 to 8 weeks after the fracture, that whether it is happening or not, looking at the dome of the body of the talus on the x-rays. So Hawkins sign is also important. Now, if we talk about this classification system, that Hawkins has divided the fractures into 4 different types. The type 1 is the talar neck fracture without any subluxation or dislocation around the ankle or the subtalar joint. So type 1 simple is there is a fracture neck of talus with no dislocation. So this is the simplest type of the fracture. And the possibility of the non-union or osteonecrosis head of the femur are less likely in these cases. Now, the type 2. Now, type 2 is going to be relatively more severe because not only there is a fracture, but there is going to be a subluxation at the subtalar joint. So there is a fracture in the fracture neck of talus, and there will be a subtalar subluxation. Now it could be either subluxation or slight dislocation right? So this is type 2 fracture, as it is very clearly evident in type 1. Now in type 1, there is only a fracture in the neck of the talus region, while in type 2, there is not only a fracture, but slight amount of subluxation also at the subtalar joint. Now coming on to the type 3. Type 3 is the fracture along with subtalar as well as tibiotalar dislocation. That means there will be a dislocation of the tibiotalar as well as subtalar joint. That is type 3 injury to the ankle joint or to the neck of the talus, as it is very clearly evident over here in this case. Like there is not only a fracture, there is a subtalar dislocation as well as tibiotalar dislocation. That is type 3. So obviously, the moment you start from type 1 to type 2 to type 3, the moment you go towards type 3, there is worsening of the prognosis, all right? The outcomes are getting more and more complicated. The complications, the possibility of complications is getting higher. And finally, the type 4. The type 4 injuries are identified as not only the fracture, there will be subtalar as well as tibiotalar as well as the talonavicular dislocation or subluxation, talonavicular instability. So here what is happening in this case? There is a fracture, there is subtalar dislocation, there is tibiotalar dislocation, and there is a talonavicular subluxation too. So that is type 4. Hopefully everything is clear related to this particular question. That is, Hawkins classification is for fracture neck of talus, to be very specific. Point number 2, this is the detail of Hawkins classification. Point number 3, what are the important complications that every one of you should be knowing about? That secondary osteoarthritis, osteonecrosis body of the talus, and non-union. Now, because of osteonecrosis is a kind of a complication which will persist throughout life in a patient, it is very important to identify whether the bone is going into necrosis or not. In order to identify that, you are having a Hawkins sign. Now, Hawkins sign is basically the X-rays taken 6 to 8 weeks after injury to look for the sclerosis or there is a radiolucency in the dome of the talus. If there is a radiolucency, that means no osteonecrosis. If there is a sclerosis, that means beginning of the osteonecrosis in the body of the talus. All right. So as you can very clearly identify that the word Hawkins, as far as orthopedic question is concerned, is clearly a key word, all right, to the answers for the talus because of the classification system and because of the sign. So this is what you have to remember for this question number 2. Now coming on to the question number 3, and again, as I'm saying, I used to say this persistently, we are pressing you that you have to learn about this Trendelenburg thing, because now the examiners have started asking this question. The question was asked in 2014 JIPMER, and then there was a gap. No such question was asked for a long duration of time. And since last to last year, they have started again asking a question based on Trendelenburg test, because it is slightly or directly related to the examination of the hip joint, right? Now, first of all, before we jump into the Trendelenburg mechanism or the test, just try to understand it over here. If this is the head of the femur, this is neck of the femur, this is greater trochanter, lesser trochanter, and these are the two muscles which are at abductors, the primary abductors of the hip joint, having some assisted action of extension, flexion, as well as rotation of the hip joint. And these two interesting muscles are gluteus medius. They are gluteus medius and gluteus minimus, right? And both of them are supplied by superior gluteal nerve. They are supplied by superior gluteal nerve, as you already know about this. Now, there is an abductor mechanism of the hip joint that when you stand on one hip, imagine you are standing on this right hip of the patient. When you stand on one hip, then the force which is generated by these two muscles will be transmitted and it will try to pull the other side of the pelvis up. You know, if you are standing on one side, then the weight bearing has to be shifted towards one side. The center of mass of your body has to be shifted towards that weight bearing side, on the side on which you are bearing the entire weight of the body in order to attain the stability. Now, what is that mechanism which is pulling the body to get inclined towards the weight bearing side? That mechanism is abductor mechanism of the hip joint. And how the abductor mechanism works, that the gluteus medius, the gluteus minimus, they contract, they generate force which get transmitted and try to pull the other side of the pelvis towards the weight bearing side, right? So the body gets inclined towards the weight bearing side. Imagine if these two muscles are injured, or if there is a nerve injury which is supplying to these two muscles, then obviously what will happen, that when you try to bear weight on that affected limb, then the force is inadequately generated or not generated. When there is no force generated, then there will be a failure to lift the pelvis onto the weight bearing limb, as a result of which the side which is hanging off the ground will be dropped down. Alright, there will be drooping of the pelvis on the normal side. So this is exactly what the Trendelenburg test positive is. Now, if you go back to the question was asked that there are several structures which are mentioned in the options, and they have asked that multiple options could be correct. Some of the options are not contributory to this abductor mechanism of the hip joint. If you look at the question, that while bearing weight on the right lower limb, now when the patient has started bearing weight on the right lower limb, the pelvis dropped down towards the left side. That means abductor mechanism of the right side is inefficient. Now, which of the following structures are likely to be affected? As you know, the superior gluteal nerve, yes, because it is responsible for supplying the gluteus medius and minimus, the generators of the force, which is responsible for lifting the other side of the pelvis towards the weight-bearing limb. Gluteus medius, yes, it is a component. Gluteus minimus, yes, it is also a component. And you know, gluteus maximus is not a component. It is the major extensor of the hip joint, which is supplied by inferior gluteal nerve. The sciatic nerve is not at all a component because it is responsible for supplying the muscles lower in the lower limb. So sciatic nerve is not a component. So multiple options correct means option number A, option number B, and option number C. So these are the three options which are correct in this particular situation. So while bearing weight on the lower limb, the pelvis dropped down towards the left side. That means right-sided abductor mechanism is at fault. And you know, last time the question was asked that which of the following nerve is likely to be affected: right-sided superior, left-sided superior, right-sided inferior, or left-sided inferior gluteal nerve palsy. So again, the same thing they are asking regularly about the Trendelenburg test, Trendelenburg gait, Trendelenburg components, the abductor mechanism, and next time they are going to ask about the contraindications. The next time they will be asking about the options, that in which of the following condition the Trendelenburg test is positive. So for that, you just have to learn very thoroughly what exactly the Trendelenburg mechanism is, because it's not like that in one patient who is suffering from tuberculosis, for example, one patient can perform Trendelenburg where the Trendelenburg test could be identified as negative, and the other patient who is also suffering from the same disease, tuberculosis of the hip joint, Trendelenburg test could be positive. So there are multiple requisites which are required to be understood in order to identify and mark the answer related to the Trendelenburg test. So this was obviously a very obvious question with a very obvious answer. All right. Another very practical question, the Bankard lesion. You know, dislocation of the shoulder joint is a kind of the topic which they are asking again and again. And now this time they have asked a complication which is related to the shoulder joint dislocation. So what is that? A Bankard lesion. Now just try to understand. Imagine this is a bone, that is glenoid bone. Over to that there is a fibrocartilaginous structure which is known as glenoid labrum. So this is glenoid labrum. Now every time there is a trauma which is responsible for thrusting the head of the humerus to move out of this glenoid labrum. All right. When the head of the humerus is thrusted out of the glenoid labrum, then there is a likely possibility that it could lead to a stretched injury. It could lead to an impacted injury onto the antero-inferior part of the glenoid bone as well as to that of the labrum. So if you look at this glenoid bone over here, and which is covered by this fibrocartilaginous structure. So here, if there is a lesion over here in this region, antero-inferior part of the glenoid labrum, not only labrum, there could be a affection of the glenoid bone also. Like some region of the bone could be detached because of the acute traumatic event. So this is known as Bankard lesion. So it could be a complication of the shoulder dislocation, or it could be just a impactful injury for the first time that is happening. So that is known as Bankard lesion. All right. It is considered to be a pathological identifying lesion for the recurrent dislocation of the shoulder joint. So what is Bankard lesion? As you know, Antero, once you have understood that every time the shoulder is getting dislocated anteriorly, so obviously the anterior part of the glenoid labrum would be affected, and inferior part. So it is the avulsion from the antero-inferior part of the glenoid labrum. So that is what the Bankard lesion is. Now, if you look at the other option, other options related to the dislocation of the shoulder joint are the heel sac lesions. What is heel sac lesion? This is another complication for recurrent dislocation of the shoulder. Now, every time there is a shoulder which is dislocated anteriorly, the anterior rim of the glenoid will impact onto the posterior surface of the humerus. And this impact on the posterior surface of the humerus will create a depression. And if you want to be more specific that where on the posterior surface, then on the posterolateral surface, because the head of the humerus, it glides medially. So the posterolateral surface is exposed to the anterior rim of the glenoid. So that is all what is heel sac lesion is. So if you look at the option number C, the depression on the posterolateral part of the head of the humerus, it is actually the heel sac lesion, which is a feature of recurrent anterior dislocation of the shoulder. On the other hand, the depression on the anteromedial part of the head of the humerus is a reverse heel sac lesion, which is a lesion of recurrent posterior dislocation of the head of the humerus, right? Or the shoulder joint. Because when it is getting dislocated posteriorly, the posterior rim of the glenoid will be having an impact onto the anterior surface of the head of the humerus, and that specifically on the medial side. So there will be a depression on the anteromedial surface head of the humerus, which is a result of recurrent posterior dislocation of the shoulder and is known as reverse heel sac lesion. So hopefully everything is clear related to this, a very, very easily identified kind of a question that is known as Bankard lesion, right? So although we can say that the questions were not exactly a direct sort of a question, but nothing was not there in your that you haven't read about, right? Everything you already know about it. Bankard lesion. All right. Hopefully this question is also clear. And finally, again, they are asking this question, foot drop they have asked. Name of the nerve which is likely to be injured with this particular case they have asked. Right? The name of the splint which might be required in the management of this condition, they have already asked. And we have taught this with the hope that one day they will start asking about these gait abnormalities. That means how the patient walks with these weak muscles, with the paralyzed muscles. What are the compensatory mechanisms that the patient takes in order to walk forward, right? So they have started asking about the gait, and the name of the gait with this kind of an injury is going to be a result of a common peroneal nerve injury. Now just try to understand. The name of the fracture over here is the fracture in the proximal aspect of the fibula. So it is the proximal fibular fractures. Now as you know very, very, very clearly that this common peroneal nerve is lying in closed approximation in the proximal aspect of the fibula. So if there is a fracture in the head, fracture in the neck, fracture in the head-neck interface, that means anywhere in the proximal aspect of the fibula, then common peroneal nerve is likely to be injured. And this common peroneal nerve is responsible for supplying, this common peroneal nerve is responsible for supplying one of the muscles, that is tibialis anterior. Tibialis anterior. And what is the major function of this tibialis anterior? It is responsible for causing dorsiflexion of the ankle. And if there is a loss of dorsiflexion of the ankle, then the patient would be having a foot drop. So as a result of which, the outcome of this loss of dorsiflexion of the ankle, it will result in foot drop. Now, imagine how the patient with the foot drop will walk. Normally, how you walk, you are having the ankle joint in extension, and this is how you walk. This is how you will perform a heel strike. After heel strike, there will be mid stance, then there will be heel off, and finally there will be toes off. So these are the phases of the stance phase of the gait cycle. Now imagine if the patient is having a foot drop, he won't be able to perform the heel strike. And once he is not able to perform this heel strike, the heel would be kept in plantar flexion. So he will walk by dragging the toes on the ground. Now in order to prevent this drag injury to the toes, he will take a higher step. In order to have a clearance of this foot, he will take a higher step in comparison to the normal because of the plantarly flexed foot. So this is what is known as high stepping gait, because he is taking a compensatory higher step to prevent the dragged injury or dragging injury to the dorsal surface of the toes. High stepping gait. So high stepping gait is because of the common peroneal nerve injury. So fibular fracture causes high stepping gait, right? As far as waddling gait is concerned, it is bilateral Trendelenburg gait. As far as extensor lurch is concerned, it is because of gluteus maximus abnormality. As far as broad base gait is concerned, it could be anything, right from the coxa vara up to the bow legs, right? So, or the genu valgum. So, means these are the kind of the questions which the examiner will ask again and again now, because these are very practically seen on day-to-day basis in your OPDs. So, fracture neck of fibula, it will cause a high stepping gait. You came to know the reason. Common peroneal nerve is likely to be injured, leading to the paralysis of tibialis anterior, loss of dorsiflexion. How the patient will walk? With a high stepping gait, in order to have a better clearance on the ground, because he won't be able to perform the heel strike of the stance phase in the gait cycle. So hopefully everything is clear. One more question was there, which was related to the anterior cruciate ligament injury on the MRI. The sagittal view was provided, but it is going to be better covered under the radiology section, where sir is going to teach you everything related to the aspect of identifying on different weighed images, right? So, hopefully everything is clear. If you go back to the question, what new we might have learned in this particular session was that, three bony point relationship is something that you already are aware of. Name of the classification is ever taught, but this time we are talking about the complications, we are talking about the detailed classification system, and we are talking about this sign which is related to the prognosis of the talar fractures. Trendelenburg gait, Trendelenburg test is something which they are asking every year for the last 1 to 2 years. Then Bankard Legion, very obvious answer for this particular question. And then finally, the fracture neck of fibula. It will cause a high stepping kind of the gait abnormality. Hopefully the session was helpful. Hopefully you have performed the paper well. All the best for your future examinations. Thank you very much.